So good afternoon, everyone, and welcome to the American Brain Coalition's educational webinar, Beyond the Diagnosis, the Risk and Real-World Impact of Brain Health. I'm Christine Buckley, Executive Director of the Brain Aneurysm Foundation and Chair of ABC's Programming, Engagement, and Outreach Committee. ABC member patient advocacy groups play a critical role in bringing the lived experiences of individuals and families to the forefront, ensuring that research, care, and policy are grounded in real-world needs. Your voices help illuminate the daily impact of brain conditions, turning data into human stories that drive urgency and action. At the same time, ABC's professional members contribute scientific expertise and clinical insight, helping to translate emerging research into meaningful advances in prevention, diagnosis, and treatment. Together, these communities create a powerful bridge between science and society, deepening our understanding of brain health, risks, and highlighting their far-reaching consequences for individuals, families, and healthcare systems. We hope today's webinar will support our members by offering a high-level overview of the global burden of brain health. There will be time for the audience Q&A at the end of the program, so feel free to submit your questions at any time using the Q&A box on your screen. And today we're honored to hear from Dr. Angela Appice, a research assistant professor and lead research scientist, Dr. Jamie Steinmetz, and Dr. Amy Lestuka, all at the Institute of Health Metrics and Evaluation at the University of Washington. Dr. Appice co-leads a development assistance for health resource tracking team, which produces global estimates of resource flows from high-income countries to low and middle-income countries, aimed at the maintenance and improvement of health. Her research interests center on health financing, resource allocation, and the economic impact of diseases. She's developed expertise in tracking and analyzing the flow of financial resources from national and donor governments towards health-related activities. Dr. Jamie Steinmetz directs sensory and neurological disease burden estimation for the Global Burden of Disease Study. Her work quantifies the global impact of brain disorders to inform international health policy. And Dr. Amy Lestuka leads an IHME team that focuses on measuring the direct and indirect costs of Alzheimer's disease and other brain health conditions in the United States and globally. Dr. Appice, the floor is yours.
Thank you, Christine. Amy, can we share the slide? Next slide, thank you. So this is a high-level outline of our talk for today. We'll share a high-level overview of the Institute, and then we will focus first on the neurological health and risk factors before we delve into the economic impacts of brain health. Next slide. A bit about the Institute for Health Metrics and Evaluation, IHME. IHME is a research institute at the University of Washington. The mission of the institute is all people living lives in full health. And so towards that goal, it provides comprehensive data and analytic guidance to support local and global efforts to improve health. We have three broad areas of work: epidemiological and societal burden of disease, including the historic and future patterns in burden. Second area focused on health economics, including tracking the financial resources, targeting health activities, amongst many others. And lastly, work focused on intervention and treatment impact simulation. Next slide. A major project at the Institute is the Global Burden of Disease Study. It measures outcomes in a comprehensive and comparable way for all countries. Currently, it covers 204 countries and territories, including 900 plus subnational units, and estimates are disaggregated by age, sex, location, and across time, starting in 1990 and with forecasts through 2050. Next slide. A lot of the data that is produced at IHME is made publicly available for use by anyone who's interested. We have various interactive visualizations at healthdata.org. But one particular site that I want to make sure to highlight, because it might be of interest to you, is our Brain Health Atlas website, brainhealthatlas.org. You will find most of the information that we will be presenting today on the site and more, so please check it out. Next slide. I now pass it over to Jamie to tell us about the neurological health burden. Thanks.
Thanks, Angela. And thanks to all of you for the opportunity to talk to you about our work on the burden of neurological health loss across the lifespan, as well as some of our work on associated modifiable risk factors. Next slide, please. So the impetus for the work that I'm going to talk to you about comes from a collaboration with the World Health Organization, where we really wanted to recognize that there's a very diverse set of conditions that contribute to neurological health and neurological health loss, and ultimately to brain health as well. So we partnered with the WHO and came up with a novel method together to quantify neurological health loss across the life course. So from beginning of life all the way through old age, covering 37 distinct conditions that we estimate in the Global Burden of Disease study, and do this in a way that was standardized and allowed us to create a framework where we could kind of look at temporal trends, look at differences geographically, et cetera. So again, this, really the goal here was to say that there are many diverse conditions that impact the nervous system. We think this method will let us monitor and assess health over time, and also assess, achievement of global benchmarks, and really support brain health advocacy using a life course approach. And I'll talk more about what we mean by that shortly. Next slide, please. So I just want to introduce you to the conditions that we included in this envelope. What I'm referring to is this neurological envelope, trying to capture all health loss associated with the nervous system. And you can see that I've grouped these 37 conditions into their kind of primary categories. So this ranges from what we kind of consider as primary neurological conditions in dark blue, infectious conditions, neurodevelopmental, cancers, injuries, and then neonatal and congenital conditions as well. And so what we were able to do, just very briefly, is isolate the portion of health loss, so the number of individuals and then the portion of health loss that was directly related to neurological health. So you can see that some of these conditions, for example, COVID-19 being a timely one, impact a bunch of different systems, right? So certainly the respiratory system, et cetera. And what we were really interested in was that subset of individuals who experience health loss directly due to, say, changes in cognition. So the measures that we estimated, again, just briefly on methods, are prevalent. So how many people experience these different conditions and the totality of these conditions, how many people are dying from these conditions, and then a few measures that are, I think, unique or developed at IHME. The first is years lived with disability. So this is trying to capture not just prevalence, but the degree of health loss due to these conditions. So you can think of something, for example, like a very minor common cold that has extremely high prevalence, but relatively low levels of health loss associated with it. And so that would be reflected in kind of down weighting the years lived with disability. And then you can imagine a condition that is much rarer, but leads to very large amounts of lived health loss, and that would be upweighted accordingly. Years of life lost then is another way of thinking about death. So it's not just the number of people who die from a given condition, but how far away they were from life expectancy. So this can increase the prominence of conditions that lead to death well before life expectancy. And then disability adjusted life years is just the combination of those two. So I'll be referring to disability adjusted life years, or DALYs, throughout this portion of the talk. And you can just really think about that as the combination of non-fatal and fatal burden. So really kind of total health loss of a given condition. Next slide, please. So just to mention, if this is of interest to you, we published this work in two different places. So the collaborative work with the WHO was published in Lancet Neurology in 2024. And then more recently, we collaborated with the American Academy of Neurology to do a US-focused analysis, excuse me, which is published in JAMA Neurology. So next slide, thank you. All right, so and actually, Amy, if you can just, I didn't realize I had animation. If you could just press next slide so I can show some of these points. Thank you. Right, so I think kind of a headline finding is just to show you globally the ranking of these 37 conditions ranked from the, first, the kind of top condition that impacts health loss all the way down to the one that has the least impact on health loss, that's neurological. And so again, this is globally across all locations. Probably won't surprise anyone that in the top 10, stroke is ranked first globally and in most regions of the world. If you do look at the top 10 conditions, I think one interesting feature is that really only one infectious condition is in the top 10, so meningitis. Nervous system cancer is ranked 10th, but I'll just note that it's the second most common cancer in children under 5 after leukemia, according to our estimates. And while tension type headache is the first ranked neurological condition in terms of prevalence, so it's very common, it's not in the top 10 for DALYs, where again we're associating, we're also accounting for kind of a degree of health loss. So you can see then that migraine is ranked third, so much higher. If you could go forward, Amy, please. I do want to point out that we have a residual category called other neurological disorders, which is ranked pretty highly. So this is a category that combines a disparate set of conditions that are rare, maybe lack quality data, or are yet to be explicitly estimated in the GBD. So that would include Huntington's, say, muscular dystrophy. So there are a number of conditions that we're really motivated to explicitly estimate, but don't yet have those. If you go forward, maybe just 2 or 3 clicks. Okay. And then again, pointing out COVID, which I mentioned earlier. So that's ranked 22nd across these different conditions that impacted the nervous system. And again, that's just really picking up on long-term cognitive impacts of COVID. And I'll mention that, in the bottom half, we see globally a few conditions that aren't very, very highly ranked globally, but are high in places of endemicity. So that includes neurocysticercosis and malaria. Next, please. And then finally, again, some conditions, again, that have very geographically specific locations like Zika. All right, next slide, please. I also wanted to show you what this looked like in the US context. So this is directly from the JAMA Neurology publication that I showed earlier. So in the US, what you can see here again is ranked from the top, stroke being kind of the largest contributor to neurological health loss in the United States, all the way down to the bottom. But what this is also displaying for you is really the breakdown between non-fatal health loss for a given condition, so that's in blue, and then fatal health loss from that condition in yellow. And you can see that really varies by condition. So, for stroke, there's still a really important component or large component related to death from stroke, and as well as the non-fatal component from surviving and living with longer term impacts. Similarly for Alzheimer's disease and other dementias. And then, for something like diabetes, what we're capturing there is diabetic neuropathy. And then for migraine, we're really just capturing that lived experience of health loss. And again, you can see that this varies across different conditions. A lot of the conditions in the top 10 in the US are similar to globally, but I will point out two big differences. One is that neonatal encephalopathy, which was really a leading driver globally, is much lower ranked in the United States, so has less of an impact. And then the same for meningitis. So that's fallen out of that kind of top 10 category. And in fact, you can see that there aren't infectious conditions in the top 10 category in the US. Next slide, please. So I think a big takeaway from our work, again, switching back to thinking of a global context, is that if we look at what's happening to, kind of all neurological health loss that we've quantified over time, what you can see is that we see a decrease, which is great. But if we then think about the underlying components, which is years of life lost and years lived with disability, we see a bit of a different story. So really what's driving this overall decrease is a decrease in YLLs. And that is really very much driven by decreasing deaths due to stroke and neonatal encephalopathy over time around the world. So that's kind of a big component of why we're seeing this decrease. On the other hand, you can see that there's actually a slight increase in years lived with disability. And that's because people are surviving conditions that they might not otherwise, whether that's stroke or encephalopathy or another big driver, which is preterm birth. But then, have to live with the consequences of those conditions. And so I think a big focus that we're interested in is, rehabilitation, so it's really great that there's more survivorship from preterm birth, but then how can we help support any longer term motor or cognitive effects of that? Next slide, please. And I think another takeaway that is important to us is that neurological health loss really spans the life course. I think there can often be, this focus on neurodegeneration or later age, but I think we're really seeing that there's, effects and diverse diseases across the entire lifespan. So here, just again, showing globally what these rates of health loss look like over age. And you can see there's this large kind of U shape. There's this large component early in life, again, very much driven by some of the birth or early life conditions such as neonatal encephalopathy from birth trauma or asphyxia. And then a lower number or lower rates kind of in younger or mid-adulthood, and then that rises again with the rise of stroke, neurodegeneration, and effects of diabetes. Next slide, please. And I think this is another really nice way at looking at this idea that neurological health loss spans the life course. So this is from the WHO Global Status Report using the results of this analysis, which is a really great report if you haven't had a chance to look at it. And what they're showing is the top 5 conditions for different kind of key age groups. And I think this just really nicely displays, the diversity of conditions and how the impactful conditions transitions depending on the point in the life course that you're looking at, right? So under 5, again, you see neonatal encephalopathy, some infections around the world, neural tube defects, et cetera. As you get into age 15 to 19, you start to see the rise of headaches, also the consequences of preterm birth, epilepsy, and neurodevelopmental conditions. 20 to 59, you start to see stroke coming in. Also still a lot of prominence of migraine, beginning to see the effects of diabetes. And then as you get into 60 plus, you start to really see the prominence of strokes, dementia, Parkinson's disease, et cetera. So I think this is really our way of thinking about the life course approach. Next slide, please. And I think, again, on the global level, I think another thing that was really striking to us is that the global distribution of neurological health loss is just extremely inequitable and unbalanced. About 85 to 90% of health loss is located in low and middle income locations. And so you can see that, I think, quite strikingly here in this geographic map. But again, this is very driven by years lived with disability, so that fatal or death component, and very driven by stroke and neonatal encephalopathy. So if you switch to the next slide, I'm going to show you what this map looks like if we're just focused on years lived with disability. So again, this is the non-fatal burden, surviving conditions and living with consequences, where you can see actually that the distribution is much more similar across the world. So again, there's kind of two different pictures there. Next slide, please. And one other thing that we were interested in quantifying is, the role of modifiable risk factors. Of course, prevention is a key thing that we're interested in at our institute. And so what I'm showing you here is on the left, I'm listing modifiable risk factors. And then on the top in the columns, I'm listing, kind of key primary neurological conditions. And I've placed an X anywhere where we've quantified the relationship between that particular risk factor and a disease outcome. And so I think what you can immediately notice is that there's a lot of blank space on this table. So there's a lot of neurological conditions, impact brain health, where we really don't, at least at our institute, haven't quantified, what are the attributable or driving forces, and we think that's like a really key thing that we need to focus on going forward. We have a pretty good handle on stroke. About 17, 18 different risk factors have been quantified, including a bunch of the diet components that you can see here. We're currently working on Parkinson's disease with support from Michael J. Fox Foundation. And what I want to end with is just talking a bit about our work in the past few years, looking at risk factors for Alzheimer's disease and other dementias. So prior to the project that I'll briefly explain to you, we really only were looking at a handful of risk factors for dementia, but we've expanded that list substantially. So if you could go to the next slide, Amy, I will just briefly talk through that work with you. So this was a project that was supported by AARP and the Alzheimer's disease and ADDI, excuse me. And we really wanted to focus on dementia because we know it's a top 5 cause of health loss. So not just top 5 cause of neurological health loss, just all health loss in adults age 60 plus. We've also shown through previous work that we project that global cases will approximately triple up to about 150 million or more cases of dementia by 2050 if everything remains the same as current. And so, because of this, we know that prevention is kind of a key aspect of work on dementia. So we've developed methods at IHME, which I won't go into in depth right now, though I'm happy to take questions, which allow us to, it's called the burden of proof methodology, and it allows us to assess risk factors across their exposure continuum. So instead of something like a binary, are you exposed to this risk factor or not? We're able to say, well, what if you're exposed to low levels of this risk factor? What does that do to your dementia risk, or higher levels, et cetera, and really see how that changes over the exposure continuum. And then we're also able to rank the strength of the evidence between disparate risk factors. So really be able to say which of these risk factors is most important to target when we're thinking about intervention. And then we're also able to estimate avertable burden. Next slide, please. So we focused on 12 risk factors for dementia. You might recognize that these are 12 risk factors that were highlighted in the Lancet Commission on Dementia from 2020, which was around when we were starting to think through this project. And it is, of course, seminal work. And so you can see this is a really diverse set of risk factors, spans behavioral, environmental, and metabolic risk factors. And so again, we were able to use our methodology to really rank the importance of each of these. And when I say that, ranking the importance or strength of the evidence, what I mean is both the magnitude of effect. So how much do these risk factors increase the risk of dementia, but also the consistency of the underlying evidence. So we run systematic reviews and try to find all studies that are looking at the relationship between these risk factors and dementia. And we have higher strength of the evidence if they're quite consistent, and lower strength of the evidence if studies are saying wildly different things about what that risk would look like. Next slide, please. So I really just want to do a broad overview. So I just want to summarize our findings across all risks. So what you can see on the left is a table where I'm listing the risk factors, and then they're ordered by the strength of the evidence. So again, magnitude of effect on dementia and consistency of the underlying evidence. And so I think what you can see is that our top rated risks in terms of strength of the evidence are high fasting plasma glucose, hearing loss, and lower educational attainment, followed by another subset of risks where we would have what we'd call weaker evidence. And then finally, body mass index, which we actually think is a pretty large driver of dementia risk, but the underlying data is relatively inconsistent. We do know that it's midlife increased body mass index that has the biggest impact on dementia risk, but there aren't a lot of studies that have looked at that rigorously. So I thought I would just highlight 3 of these risks for you, starting with our top ranked risk, which is high fasting plasma glucose. And I think our key finding here is that we see that dementia risk begins to rise even before you hit the diabetes threshold. So at pre-diabetic FPG levels, say between 6.1 and 7, we're already seeing a marked increased risk of dementia. And that's really important because a large population globally and in the US is sitting within that range. So we think that's an important target. Hearing loss, wanted to highlight that as well. So it's also one of our top ranked risks. And we estimate like over 1 billion people experience hearing loss around the world. We're seeing increased risks, not just with full deafness, but with moderate thresholds of hearing loss of around 30, 35 decibels. And we also have estimated at IHME that only about 10% or less of people who need or could benefit from hearing aids have access to those globally. So also think this is an important target. And then finally, I'll just highlight physical activity. What we found is that if you follow the HHS recommendation of about 150 minutes of moderate activity per week, that's associated with a 20% reduction in dementia risk. So we also think, this is a protective risk factor, and think that that's something really worth highlighting and thinking about from a policy level. Next slide, please. Okay. So I just want to end with a few slides where I just mentioned that one thing we can do is we can take these risk relationships and we can combine them with our estimates of exposure level and burden of dementia in a given country in order to calculate attributable burden. So you could imagine you have a really, really strong relationship with a risk, but the risk is in very low levels in the population. It's not actually going to have, in that context, a huge impact on dementia burden. But if you have a lot of a risk in a given place and it has a big association with dementia, it's going to have a larger impact on dementia. So these are again ranked, and what I'm showing you is global on the left and in the US context on the right. And then I've put in a box the kind of top 5 risk factors in terms of actual impact on dementia health loss that's directly attributed to each of these risk factors. And I think what I want to point out is you can see that lower education is really, really important globally, but a little bit less so in the US. In the US, our big drivers are fasting plasma glucose and body mass index, hearing loss, education, and blood pressure. Whereas you can see globally that there's also high ranking for air pollution compared to the US. Next slide, please. Just wanted to share a few examples of outputs from this project. We do have a full project report that's really focused on the US with figures like what you're seeing here. So this is just examples for air pollution where we're showing health loss by state so that you can see state by state differences for each of the risks that we've looked at. Also showing you kind of the proportion of total health loss in the US from dementia that can be attributed to each of these risks. And then we have other related publications as well. Next slide. So just to end, I think the big takeaways, nervous system damage causes a lot of health loss. They're not just diseases of old age. The global distribution is not very equitable, as I showed you with those maps. Burdens decreasing over time, but that pattern masks diverse patterns by condition. And we want to do more work on modifiable risk factors, but for dementia, the strongest evidence was associated with fasting glucose, hearing, and educational attainment. Thanks.
Thanks, Jamie. I will come in here to talk about our work estimating the economic burden of brain health disorders. Next slide. So the results I'll be presenting are part of a project at IHME called the Brain Health Initiative. And the Brain Health Initiative aims to empower individuals, communities, and healthcare systems with the resources they need to improve brain health outcome. Its mission is to reduce the global burden of brain disorders through research, improve the understanding of brain health, and foster collaborations needed to bridge significant data gap. Its goal is to quantify the health and economic burden in order to motivate policy change and mobilize resources. Next slide. I think you missed a slide, Amy. Okay, this is the next slide. Okay, so for the economic burden aspect of the project, we focused on measuring comprehensively both direct spending and indirect spending. But the study itself covers 6 types of healthcare services, 204 countries and territories by age and sex for 22 brain disorders from 2000 through 2019. And the slide highlights the different brain disorders according to the various categories. Next slide. Okay, so focusing in particular on how we measured or estimated the economic burden, we aimed to do this comprehensively. So that meant that we included both direct spending and the indirect costs. For direct spending, that meant quantifying actual spending on professional medical care. This is inclusive of doctor visits, hospitalizations, emergency department use, medications, nursing home, and home health care. For indirect costs, conceptually, we framed it to include lost income from caregiver, lost income from the patients themselves, non-market productivity, lost tax revenue, and transportation costs. However, our current results primarily capture the lost income from caregivers, but we started off framing this in a very broad sense with the aim to eventually be able to estimate all these indirect costs as well. Next slide. So how did we generate the estimates we're reporting? At a very high level, we have 2 steps. First, we used prevalence and incidence data from the Global Burden of Disease study, as well as relative price, or also could be thought of as unit cost data from the various conditions from a project at IHME focused on estimating the expenditure on various diseases. And then we also pulled data on national health spending from the WHO in order to make sure that estimates fit what had already been estimated as overall national health spending across the various countries. So from these 3 components, disease prevalence data, relative prices, and the scaling factor, we generated an initial estimate of spending across the various conditions of interest. And then as a second step, we completed a literature review on the costs that had been published for all the conditions in the study. Once we were able to extract the cost estimates from the literature, we leveraged this data as well as modeling techniques to adjust the initial estimates we had created in the first step to be comparable and credible based on existing published estimates. Next slide. Now to some results. Next slide. Okay, so we are estimating globally that 1.7 trillion was spent on direct health care for various brain disorder conditions in 2019. 52% of that were related to neurological conditions and 48% to mental health disorders. And between 2000 and 2019, the spending on these brain health conditions grew at an annual rate of 3.5%. And so here we're showing a stacked bar that highlights the different the spending on the different conditions over time. The stars show the conditions that are contributing the most in terms of the overall direct spending. So we have stroke and Alzheimer's, as well as anxiety disorders. Next slide. Thanks, Amy. So next, we look specifically at neurological conditions disaggregated by age for the US to your right and globally to your left. So we are looking at a stack bar flipped, if you will look at it that way. So your y-axis is by age group. We have the different age groups in 5-year buckets, and our spending estimates on the x-axis. So we see that for neurological conditions globally, almost 9 billion was spent. A third of that was spent in the US. And spending is higher in the older age groups, with female spending on related to Alzheimer's being quite high if you're looking at the 85 plus bar for both the global figure and the US spending. For the US, spending is also high in the older age group, but there's quite a bit of high spending as well for women on multiple sclerosis. If you look at the salmon color in the middle range of the bars. Next slide. Here we focus on mental health conditions. And so for that, globally, 830 billion was spent. And again, about a third of that was spent in the US. Across age and sex, the overall pattern is similar. We have high spending amongst the youth, especially between age 5 to 19, driven by autism and attention deficit disorders. But you would note that there's substantial spending from that age range all the way to about the 60 years old age range as well. Next slide. Here we look at two figures related to the type of care and how that has evolved over time. We see that for neurological conditions, globally, inpatient care has risen, and this is the same as well for the US. But in the US, we see that ambulatory costs is also rising as well, driven by opioid use and anxiety disorders, care seeking. Next slide. Again, looking at type of care evolution spending evolution, but here focused on mental health conditions. And the big thing we note here is that a lot of that spending is in ambulatory care, both the global level and then in the US. Next slide. Okay, so some key takeaways from work looking at global and US specific spending, direct spending on brain health conditions. We see that globally and in the US context, direct spending on brain health conditions, inclusive of neurological and mental health conditions, is significant. Spending is high on inpatient care services, especially related to neurological conditions. We also note that mental health spending in the age range between 5 and 19 is high. And spending on ambulatory care services for mental health conditions is also increasing. This is both globally and for the US. And in addition, for the US, for neurological conditions, the spending associated with that in ambulatory care services is also rising. Next slide. I pass to Amy to give us the results on lost income for care related to caregiving.
Great, thanks, Angela. Yeah, thanks so much to the organizers too. I'm excited to be here to talk about these results. So yeah, I'm going to jump into this part of indirect costs that Angela mentioned earlier, which is the lost income that caregivers experience when they're caring for someone with one of these, many brain health conditions that we're covering. I just want to also give a quick shout out to the team that helped develop these results. We had a really excellent team of several folks that put all these results together. It was a pretty big project. And this was a fun challenge to try to figure out how much income caregivers are losing, because there's several pieces that you need to understand. So I put this sort of high level equation in red at the top. So we're looking at caregiver prevalence rather than the prevalence of the condition, which we could get directly from the global burden of disease. So for caregivers, we need to understand who's providing the care. So what's their age and sex? Because age and sex are very important in terms of what their wages would be. And then how many people with a given condition receive care? Because for many of these conditions, people are not necessarily getting any unpaid care. We have, and especially on, I would say on the mental health side, there's fewer studies kind of examining how many people get unpaid care. Like headaches, for example, was one where it's hard to find information. And we figure, most people with headaches probably aren't receiving a ton of unpaid care. So we needed to figure out how to account for that. So once we figure out who the caregivers are, we then need to figure out how the care hours translate to lost work. So we were able to use survey data that's actually time use survey. So people are tracking their time in detail as far as what they're doing in a given day. And then we could come up with a function translating, if you provide this many unpaid hours of care, this is how many fewer hours of work you would likely be doing. And then, we also had to figure out for each condition, how many unpaid care hours are the caregivers providing. So then we finally put all that together, combined with the average wages for each, country and age and sex group of caregivers to come up with a total of lost income. So here's line results. And we found that in 2021, which was the last year we had data for in this study, the total lost income globally for caregivers was about $1.7 trillion, which is actually a very similar number to our direct medical costs. So it's about 50% of that total burden when you look at both. And we can see stroke and Alzheimer's disease are the top two colors there. They definitely account for the largest cost there. And we've seen that these costs have been growing. The number of hours provided has been growing about 3% a year. So these costs are continuing to go up. And here's sort of the same chart, but US specific. So for the US, it was actually almost 800 billion. So in 2021. So similarly to the direct spending, we see quite a large portion of the total cost coming from the US. And, here there's a couple of reasons. One is that wages are relatively high in the US. And so these costs are a function of caregiver wages as well as the disease prevalence. So here I'm going to show a couple of charts where we look at caregivers by age. And so this is just an aggregation of all the conditions, but I found these results to be really interesting, looking at, what do we see as far as who's providing how much care? On the top is global, and then the bottom, the same thing is for the US. So the light green bars here are showing the total hours of unpaid care. And then the darker green are showing how many of those hours translated into lost work hours. So as I mentioned earlier, we kind of came up with a function to translate unpaid care into lost work. And it's a nonlinear function. So it starts out as you're providing, a few hours of care, you're not seeing a large impact on work because people are able to juggle, some amount of care and not impact their work. And then the work hours start to kind of decrease faster and faster as you are providing more unpaid care. So that's what we see here is, not all of the hours translate to lost work, but some subset of them do. And it's more pronounced for men. So men are on the right of this chart and women are on the left. And you can see for men, if they are providing care, they're more likely to be, substituting care instead of paid work. But we do see, probably not too surprising, sort of this age pyramid where most of the care hours are provided by older adults, age 65 plus. And we do see more total hours provided by women than men. I thought one of the really interesting findings here was that as you look at the younger ages, so the bottom bar on these charts is age 15 to 24, it does look like a more even gender split in terms of the caregivers. So I'm very curious to see if we can look at this more in the future, if this is a generational shift or if it's more due to the fact that younger folks are really only providing care if it's more of an emergency, so that it's less gender dependent, maybe multiple factors going on there. Here's a similar chart, so same kind of age breakdown, but this is looking at the lost income. So here, even though on the previous chart you could see the female caregivers provide more hours, the male caregivers are losing about the same amount of income. And that's partly because they're more likely to not work if they're providing care, and also their wages on average are higher. So I'll just do one more quick topic here, which is talking a little bit about our work specific to dementia. We had a project with Gates Ventures that was targeting Alzheimer's disease and other dementias, and we had the opportunity to look in a little more detail at the US, so I wanted to share some state level results that we had here. So I'll just share our lost caregiver income. So it's kind of the same metric I just talked about for our total brain health burden. But here we looked at some state level survey data. And I found this study really interesting because we do see quite a range in terms of this cost. And it goes all the way from the lowest cost was in the District of Columbia. We estimated $14,000 a year, all the way up to West Virginia, where we estimated $27,000 a year of lost income for caregivers. And again, I think Angela alluded to this earlier with the different components of indirect costs, but lost income is only one aspect of caregiver costs. I mean, there's caregivers who are providing a lot of time and they're not losing income, but their time is still valuable in other ways that's not captured in this metric. But we just thought that these state level differences were kind of fascinating. We did see on the direct medical spending side, there's a little bit of a trade-off where the states with the highest amount of unpaid care tended to have lower direct costs. And that's mostly driven by nursing home costs. So the more unpaid care is provided, the less people are relying on nursing homes. So you see some amount of balancing out. But we do see states that have relatively high unpaid care costs and relatively high direct costs. So there is a very unequal distribution in the US, which we're really interested to learn more about in future work. So I will kind of wrap it. And so I just wanted to kind of summarize by saying that these costs that Angela and I just showed for brain health conditions are rising, and they're really on an unsustainable trajectory with some of the prevalence of these conditions growing as populations age. So if nothing changes, it will eventually take up a very large portion of countries' health spending budgets. But one way to hopefully lower these costs in the future is looking at risk factors. So tying back to Jamie's work, we're really interested in learning more about the risk factors and then how, addressing risk factors might then impact future costs. So we're really interested in trying to expand on this work in a lot of directions, looking at the risk factors, adding more risk factors for more diseases, as Jamie mentioned earlier, and then looking at what interventions might be most cost effective in terms of risk reduction, and also looking at new treatments that come online, as there have recently been some for dementia and or for Alzheimer's disease, and there may be new treatments on the horizon for other conditions as well. And I think I will just end there unless Jamie or Angela, you want to add anything on this slide. That is all we've got. Thank you so much.
Thanks, Amy.
Yes, I want to say thanks so much to all the presenters for sharing your expertise in these critical areas of impact for our community. It was really great to hear from all of you. And right now, I'd just like to open up for questions from the audience. Please, type them in the Q&A box on your screen, and we'll do our best to get to as many as possible. And in the meantime, I have a couple I'd like to ask. What are the next steps for some of this work?
So, Amy, I think, highlighted a couple of the areas that we'll be excited to expand the work on. In addition to that, I think one of the key areas I highlighted was the other areas of indirect spending that we are yet to cover. We have good plans to do work that focuses on the lost income related to the patients themselves. But there's also lost income that we could estimate from the government perspective. As the burden of the disease is rising, government has costs in terms of transfers, and as well as just lost tax revenue from people not working. So those are all very interesting areas that and understudied for sure, that we would love to be able to find some funding to expand on.
Great. Another question here is, what are some data limitations associated with generating the various estimates?
Jamie, you want to go? Or
I'll jump in on that one.
Yes. Okay, good.
I feel like I touched on that a little bit when I was talking about the caregivers and how I think one thing we would love to have more data on is, how many people with each of these conditions are receiving unpaid care and how much care and who is providing that care. We did have to make some amount of assumptions in terms of the ages of the caregivers, for example. And then just some of these conditions we didn't find good cost studies on in general. And we're continuing to look and update these studies. But opioid use disorder is one that jumped out to me as not having a lot of good cost data, and is also very different the way it's treated in the US compared to other countries. So we really would like to have more global data for some of these conditions to get a better representation across the world for how the costs vary.
Excellent.
Absolutely.
Thanks.
I re-emphasize that. I think one of the biggest takeaway, at least for me, from doing this work, trying to understand just the global burden from the economic perspective, was how limited the data was for other regions of the world in terms of trying to understand the economic burden related to these brain health conditions, despite the increase in prevalence of these diseases as well. So,
Okay, thank you. And here's another question. Is INPH included in other dementia? Also, is pediatric hydrocephalus included in premature births or coupled with those who also have spina bifida?
Yeah, great questions. So for dementia, we're estimating over age 40 and trying to capture all dementias. If you want to follow up with me, I'm happy to share ICD codes included in that, which are used for a subset of our studies. A lot of, like I mentioned, other neurological disorders is this 14th ranked category, which is really a grab bag of conditions, including some of these early life conditions. I have to double check, but I think that's where, I think that's where that would be housed actually. So, I think this is it's an issue for us. There's a lot of conditions that we don't have great data, and so we just kind of house them together. But it's really hard epidemiologically or from a policy perspective to work with that sort of residual category. So for me, in terms of next steps, I think, our biggest interest is when we're able to start explicitly estimating some of those conditions, and we get input from collaborators such as this group, who are experts in a particular field who can direct us to key data sources.
Okay, and just one last question. What do your findings tell us about the support that caregivers need?
Yeah, I can take that one. So, as I showed the lost income kind of age pyramids there, we do see the biggest loss in that 45 to 54 age range, which kind of translates to usually people's peak earning years. So I think it's important to try to target support to working caregivers or people of working age who maybe had to give up work, or maybe their career trajectory is stalled because they're not taking that promotion because they're caregiving. And I think one thing that actually we don't really capture in this analysis is the longer term impact. So the younger caregivers, there's some studies showing that they may go on to get less schooling or, earn less in the future if they're doing a lot of caregiving at early ages. So I think more work needs to be done on that, but definitely supporting, financially the younger caregivers is important.
Yeah, excellent. Totally agree. But as we close, I really want to just thank everyone so much, our incredible speakers from the Institute for Health Metrics and Evaluation at the University of Washington for sharing their time and expertise with us today. It was really great information. And for anyone interested in learning more about IHME, please check out their website listed on the slide. And a big thank you to everybody who joined us today and a great day, great rest of the day. Thank you.